Hello everyone. We are part of the Pediatric Spinal team at the SRCC Children's Hospital managed by Narayana Health, and today we will be discussing a very important topic affecting the pediatric spine, which is scoliosis. I am Dr. Sambhav Shah. I am the Pediatric Spinal Surgeon at this hospital, and joined by me is my colleague Dr. Akhil.
Hello everyone. I am Dr. Akhil Tawari. I am also a consultant pediatric spine surgeon. Both I and Sambhav work together in this pediatric spine department here. So to begin with, I'll first like Sambhav to elaborate on a few questions that the patient's relatives usually ask us when they see us for a consult. And so Sambhav, can you elaborate what exactly is scoliosis?
Yeah, so scoliosis is basically an abnormal curvature in your spine. So most of us have a straight spine, but there are children that with time as they age, their spine starts curving like a C-shaped or a S-shaped, because of which they start developing an abnormal deformity, which can be visible to themselves in the mirror or to their parents as well. And there are various types of scoliosis also present, and I would like Akhil to elaborate on those as well.
Correct. So firstly, the most important scoliosis that Dr. Sambhav already mentioned is categorized as idiopathic scoliosis. So by idiopathic, we mean that nobody actually knows what is the cause of the scoliosis, but it just happens. And a majority of the patients of scoliosis that we see fall in the category of idiopathic. However, the child can develop scoliosis because of some underlying disorders of the muscles and nerves, which are called as neuromuscular scoliosis, or it can be a general condition like a syndrome, which is called as a syndromic scoliosis. How to pick up and when to do what, that would be the forwarding discussion now.
And just one more thing which I would like to elaborate on is also called as a congenital scoliosis, which is basically that a child is born with a congenital defect in his spine, because of which the spine starts curving. And obviously the congenital, the neuromuscular scoliosis, the syndromic scoliosis are picked up at a much earlier age, because there is some syndrome associated with it, and the child visits the pediatrician at a much earlier stage, and it is picked up by the pediatricians at that stage. Our focus is going to be more about the adolescent idiopathic scoliosis, which is often missed at the right time. And if it is picked up at the right time, then a lot can be saved for the patient. So to start with, the adolescent idiopathic scoliosis, I think, Akhil, if I'm not mistaken, the incidence of that in the world is around 2%.
That's right, that's right.
And it's slightly lower in India as well. And it is more commonly affected in girls rather than boys.
Correct.
So typically we see girls starting from the age of 9 until 14. Once they are growing, that's when we start seeing these curves. So Akhil, any tips for the parents at home as to how to pick up these curves, when they have a 9-year-old daughter and they want to see if she has scoliosis? What should they do regularly?
Correct, absolutely. So before that, a quick comment that so usually it's important that we pick these at the right time, and it's important that we pick them early, because majority of our practice, I and Dr. Sambhav both see that by the time the child comes to us, the scoliosis is extremely severe and would require some complex management. But if picked up early with the right attention, then a lot of things can be avoided. So to begin with, if you notice there is any cosmetic deformity which can comprise of the shoulders, you see that your kid's shoulders are not at the same level, one shoulder is higher than the other, or sometimes you see that one of the blades of the scapula, that is the shoulder bone, looks odd to you. Sometimes we see that the child will have a hump, or lower down if you see that the child has a waist or a hip asymmetry. So these are extremely important points to note. And also important to note is during the growth, if you see that there is any progression, because if yes, then that child definitely requires a specialist assessment.
So he's absolutely right. So a lot of these small things now, Even as parents, what you can do is, you have a look at your child while they're swimming, or, once in a year, just tell them to remove the t-shirt and just examine their back. And if you see any kind of a change or abnormality in the right or the left, then obviously you consult your specialist as early as possible. Other thing also in women, especially in girls who are 10, 11 years old, even from the front, you will see a breast asymmetry as well. Correct. And that is something which girls pick up. They themselves will come and tell you that they see a asymmetry in their breast. And that is again something which should not be missed and should be looked at. So Akhil, just one thing that, okay, if the parent sees this and is worried about, what do you think according to them should be the next step that they should take?
So if any of these conditions, which we typically call as red flags, if you see in a child, then has to be seen by a specialist. It can be a spine surgeon, but usually better to see a pediatric spine surgeon for that matter. So once you go to the office of a pediatric spine surgeon, he would typically take a detailed history, would note down how the progression is, but in order to have a definite diagnosis, after a thorough clinical examination, the child would need a routine radiograph. That would be an X-ray to see if we document any spinal asymmetry or a scoliosis. So with that, can you just elaborate what do I mean with asymmetry or a scoliosis, and what are the Scoliosis Research Society criterias for the same?
See, basically, once we have, so the best way to confirm is that on a standing X-ray. So again, this is one important thing that a lot of times the general practitioners or orthopedic surgeons as well, they get a lying down X-ray done.
Yeah, absolutely.
We require a standing X-ray.
Correct.
And what happens is a lot of patients come to us with lying down X-rays, and unnecessarily we have to subject them to another X-ray.
Correct.
So first we get a standing X-ray done and we check a whole spine. Now typically what we see is that your spine is curved. Now anything which is above 10 degrees as such is classified as a scoliosis. But again, what is important is at what age the patient is coming to us at. What is the girl, if it's a girl, then what is the menarche status? Has she started a menarche or no? Does she have a growth spurt? So there are a lot of criteria. Just the amount of scoliosis is not just the only criteria, but there are a couple of criteria which we look at. Even for example, the bone age. We do have some criteria on the X-ray where we look at the iliac crest, the forearm of the patient to see whether have they attained that growth or how much growth is going to happen, because scoliosis increases as the child grows. That's the most important thing. If your child is 16 years old and if he's as tall as the parents, the chances of that curve increasing is less because the child is not going to grow. But at the same time, if a child is 11 years old and the child is much shorter, he doesn't have a growth spurt yet. And in those patients, if I measure the curve and the curve is 30 degrees, those are the curves which are going to grow. So I look at the size of the curve, we measure it. There are special ways to measure the size. So we measure the size of the curve. We look at the shoulder asymmetry, the iliac crest asymmetry also on the X-rays. And then obviously the treatment depends on, as I said, the age of the child.
Correct.
So Akhil will elaborate you much more on what happens there.
So that's a very important point, that idiopathic scoliosis usually is a disease of growing spine, and that's why girls usually around the time they attain their menarche, wherein there is the peak height velocity that is happening, and boys a couple of years later. That's when you would get majority of the curve, which can quickly worsen. Now, at this point, if the curve is picked up early, that is, the curve is between 10 degrees to 20 degrees, we usually like to observe. Very important point to note is that the child should not be subjected to unnecessary X-rays, because a growing child, the breast tissue, everything gets affected. So we like to keep the radiological exam as less as possible. So it is imperative to get the right type of X-rays and get it right the first time. The criteria is if it is more than 20 degrees to 40 degrees, then we like to use something called as a brace. Now, bracing is extremely effective if done at the right age, and very important that the child has to be compliant with the brace, because a majority of the curves can be managed just by simple observation or by bracing, and a very minority of the curve would require some more invasive methods or complex spine surgeries.
So even on the bracing point, Yes, if it is given at the early stage, bracing is very effective. However, in a country like India, which is really hot, a brace only works if it is worn for the majority part of the day. So almost you're talking about 16 hours of the day that the brace has to be worn. And in a country like ours, which is hot most of the time, it gets very difficult. There is no studies which show that bracing makes the curve straight. So always remember this, that the brace is not going to make your child straight again, but it only prevents the curve, or it stops the progression of the curve to an extent from growing. So one aspect, as Akhil rightly said, is bracing. If once the patient comes back to us, and clinically if we see that the patient has worsened from the previous visit, then obviously we subject them to another X-ray, and then we compare both the X-rays and then take our call that what needs to be done next. Along with bracing, other things which also will not make, so these are myths. A lot of parents ask us, okay, what should I do for this curve to go away? One thing is that this curve, if it is 20 degrees, 25 degrees, it will not become 0 degrees no matter what you do. A lot of parents ask us whether hanging on a rod or exercising or swimming or going to a bone corrector, bone setter, will that help? No, it doesn't help. No matter what you do, even if you wear a brace, a 25-degree curve is not going to become 15 degrees or 0 degrees. It may remain 25 degrees. So physiotherapy, swimming, etc., it's all basically just to build up your muscles, to build up your strength. That's about it. It's not going to prevent the curve from becoming straight or growing. Now, Akhil, coming to say, if there is a child who is 12 years old with a more than 40-50 degree curve,
correct,
and the patient is already tall as a mother, say it's a 13-year-old as tall as a mother,
correct,
then would they still require surgery?
Correct. So that's a very good point. So see, the angulation between 40 degrees to 50 degrees is currently a gray zone, even internationally. The international standards say that if the curve goes beyond 50 degrees, then it is important that some surgical intervention has to be done. That would be more of cosmetic, but again, studies have been done which show that if the curve reaches 50 degrees, even if the child stops growing, because of gravity, the curve is going to progress at the rate of approximately 1 degree per year. Now that doesn't seem too much, but suppose a child is 14 years of age and we consider 1 degree per year for the next 20 years at a presentation of 50 degrees at 14 years, that is going to quickly become 70 degrees by the time the child is only young, which is 35. Then it is a problem to correct that curve in adulthood. So the point is that we have to pick them up early and try to correct it if needed then and there. There have been studies, extensive literature done that if the curve reaches a critical threshold of more than 70 to 80 degrees, then the child will start developing heart or lung related problems. They will start developing a lot of pain in the night. Once it reaches more than 100 degrees, that's a very bad point to have, because the child will start developing some neurological weakness, some muscle weakness. The level of physical activity that the child can do would also exponentially come down. So all this that we are trying to do is to identify the kid, to know the kid which can pose a problem, and to try to sort it as early as possible. Now with this, Sambhav, you mentioned that sometimes the child would require surgery also, though a minority. What are the types of surgeries, if you would like to elaborate based on age of presentation?
So see, basically, any intervention, any surgical intervention, obviously the main goal for us is to stop the progression of the curve. So any kid who is younger than 12, 11 years, generally our aim of surgery is to stop the curve from becoming worse. And number two, any kid above who has a severe curve, as it's more of a cosmetic correction. So the difference in surgeries is mainly when the children are less than 10 years old, because what happens is, the surgery for scoliosis entails putting in screws and rods, and we basically fuse that spine. So that spine which we are putting screws or correcting and making it straight, that is fused, so there will not be any growth over there. Now we can do that in a patient who's already attained that growth. However, younger children who are 7 years, 9 years, 10 years, who still have to grow, the height is going to increase, it becomes a difficult situation in these children, because then you're not allowing that much spine to grow. you're trying to fuse it, and at the same time there are a lot of issues with the implants breaking and implants failing because the spine grows from the front anyways. Now in these patients we have something called as growth rods. So our aim is, as I said, is to stop the curve from progressing. So in these patients we put something as growth rods where we try and limit the curve progressing worse, but at the same time the spine is also growing.
Correct.
Okay. There are various ways to do this. We have magnetic rods where we insert them and the rods start growing themselves. And at the same time, we have cheaper rods where we have to go back into the patient every 6 months and we grow the rod manually. Every 6 months, we distract the rod manually in the hope to buy time. So we limit the progression of the curve. At the same time, we let the spine grow. And then at a later stage, once they are 12, 14 years old, once we know that the growth is full, we have to do a second surgery and where we fix the spine completely. Now, coming to AIS curves, Arjun, Akhil, the adolescent idiopathic scoliotic curves.
Correct.
What would you say if you have a 12-year-old patient with a 40-degree curve?
Correct.
The chances of that curve growing would be the reason why we would operate that patient, or would it be more of cosmetic?
Correct. So see, again, 40 to 50 is kind of a gray zone. We can definitely observe the child or give bracing, but if a child is extremely unhappy with how the curve looks and it is affecting them psychologically, then we can discuss the surgical options with the child. But again, see, 40 to 50 degrees is actually a collective discussion that has to be had. There is no emergency in operating or any elective operation otherwise also. The child with a 40 degrees curve, if it stops there, will have a normal life. There have been numerous instances of sports persons, gymnasts, right across, which have won gold medals in Olympics, having curves between 30 to 50 degrees and absolutely living a normal, healthy life with the entire life expectancy.
He's absolutely right. We even have a Bollywood actor, a very famous actor who also has scoliosis, and he's leading an absolutely normal life. Second thing is, as Akhil said, it's more of a, cosmetic and it's a joint decision. What we also see a lot is the parents try to take the decision thinking that the child is just a kid. But please don't do that, because we do have a lot of girls today who do get really upset the way they look at themselves in the mirror. And they also don't go and discuss this with their parents, and a lot of women, especially 15 years old, 16 years old, they actually develop a lot of lack of self-confidence. They are depressed. So let this obviously be a joint decision, but I feel that the final decision whether a girl wants to get a cosmetic correction should be the girl's decision, along with her parents. But just the parents thinking that no surgery for her and letting the girl child be miserable, I think also it's not fair, and we do see a lot of this. One more thing, which a very common question which a lot of parents ask us is, okay, if I leave the curve alone, a 40-degree curve, will my patient get paralyzed? Will my daughter lose her legs in the future? Okay, what do you need to say about that?
Correct. So see, as I already mentioned, so it depends upon what is the curve at presentation, how malignant, that is how quickly the curve is progressing. The chances of that leading to paralysis is extremely low, but it is not negligible. But before the paralysis, it will affect the activities of daily living, wherein the child or the adult would think twice before doing simple physical activities, which would involve like going out to meet friends or going to the grocery shops to buy something, because they would have physical limitations because of the deformity. And I think paralysis, I would consider it to be an end stage of this particular condition. Of course, there would also be heart and lung issues that would need to be sorted because of the deformity. So yes, there is a possibility. It is extremely low, but yes, it is there.
So, as Akhil rightly said, we generally don't operate adolescent idiopathic scoliosis curve because she's going to get paralyzed. It's more to control the curve, or it's more for cosmetic deformity. And also, once these patients are operated, they have a significant good quality of life.
Absolutely.
Even if you see our scoring systems, where the self-assessment scoring systems and everything are very high, and the patients are really very happy. And one of the best examples is Princess Eugene, who is in UK, belongs to the royal family of UK, and she was operated for a scoliosis when she was 12 or 13 years old, and in fact she wore a backless dress just to promote that even in spite of scoliosis surgery, she's having an extremely normal life. Now, Akhil, something about congenital scoliosis. I mean, just what parents should take care of.
Correct. So before that, I would like to quickly point about the safety of doing a scoliosis surgery. Now, see, these are all extremely complex surgeries. The operating surgeons should know the condition, because it is different to put screws or rods in a straight spine, and it is extremely different to put screws and rods in a spine which is completely deformed or there is completely rotated. So we at Narayana, most importantly, both of us operate together. Now that makes a huge difference, because the spine surgeries become much safer. There has been again literature, and is quickly going to become a standard of care to have two experienced pediatric spine surgeons operating at the same time. It reduces the operation time, reduces the amount of bleeding, and the functional outcomes is extremely good. Sambhav, what are the ways in which you can make the spine surgeries safer that we commonly adopt at Narayana Hospital?
So number one thing is, as Akhil said, that we have to put screws in the spine. Now these screws, they are almost a millimeter away from the main spinal cord once we put them. So if our judgment is wrong in putting those screws, we can damage the spinal cord, which can ultimately lead to paralysis of the child. But what we have over here is we have something called as a computer navigation guided system, where the computer tells us as to where we have to exactly put the screw. It aids us in the direction of the screw, which makes the surgery very, very safe. Number two, we use something called as neuromonitoring, which is basically the patient's muscles, the patient's nervous system is continuously monitored by a neurophysiologist, who at every stage of the surgery tells us whether the signals which are coming from the spinal cord and the nerves, are they good, are they bad, are they worse, or what's happening. So that guides us. It tells us whether the screw I have put is in the right direction.
Correct, absolutely.
The correction I'm doing, is it safe without causing any damage to the nerves. So these are the two major things, and as Akhil rightly pointed out, that both of us operating together, I think it saves a lot for the patient, because there are two good minds working at the same time.
Yes, absolutely. And based on, so these are the majority of the chunk of patients of scoliosis. Yes, minority would come to us with neuromuscular syndromic conditions or congenital conditions. Now for the neuromuscular or syndromic, the type of curves are extremely different, and that is what we have learned and researched about the malignancy of those curves. And we have to understand that the treatment objectives for neuromuscular or a syndromic scoliosis is totally different from an adolescent idiopathic scoliosis. In the latter group of patients, that is neuromuscular or the syndromic kids, the management would mainly mean how to improve their activities of daily living, how best we can support those kids. And again, a lot of techniques are available depending upon whether we go very aggressive or not. But yes, we can make a huge difference in the lives of neuromuscular scoliosis patients and also in syndromic patients. Minority of the patients do have a condition called as congenital scoliosis. Now that is a condition that is present since birth, or it is a kind of a formation problem and is associated with kyphosis, that is another condition. So majority of these kids will have kyphoscoliosis. These conditions are totally different, but important that we be extremely aggressive in management of these kids, because if operated at the right age, the child will lead a normal life. If not operated, then these kids ending up in paralysis is extremely high. So that is how we go about when we see a patient of scoliosis, based on history, exam, what are the types, what are the treatment options available.
So along with this also, Akhil, I feel that even the team approach which we're taking is one of the most important things. So at this hospital, we also have different pediatric specialties, right? From pediatricians to pediatric endocrinologists to genetics to pediatric orthopedics, pediatric cardiac. So all these teams which have their own specialities is also a very important thing, because a lot of these patients, as you said, they're congenital, they have associated kidney issues, cardiac issues. So having a complete team approach is I think the most important in trying to manage a scoliosis patient. Just a few more pointers for parents. So one very thing which again a lot of parents ask us, Akhil, is, has the heavy school bag done this to the
Yeah, I think that is the number one question actually.
So what would you say to the parents for
Yes, so at the outset, nothing you or your child has done that has led to this condition. The school back is not responsible, the physiotherapist is not responsible, dancing is not responsible, swimming is not responsible. Nothing that the child has done is responsible. It is just that it was supposed to happen and it has happened. And that is very important point to keep in mind, because a lot of parents start blaming themselves. I know it is a difficult situation to have, but we have excellent solutions to these problems, and we would do everything that is possible to make the child attain their full potential.
Exactly, Akhil. So I think if you do see that, you do feel that your child has scoliosis or a curved spine, the first thing I think that you should do is go visit a pediatric spinal surgeon, if not at least an orthopedic surgeon to start with. Always get standing x-rays.
Absolutely.
Always tell even though the doctor doesn't say, please tell them, ask them for a standing x-ray. And obviously then go over to the specialist.
Yes.
Majority of you guys will not require anything to be done, but even if there is a requirement for a surgery, I think scoliosis surgery have been overall very, very safe.
Extremely gratifying.
And a lot of patients are really happy.
Correct.
From not just the way they look, but even the quality of life. So, Akhil, anything else to add? I think you can sum it up.
Yes, so I think, yes, scoliosis is a difficult problem, but like we say that we catch it early, we catch it young, we can make it much, much better. And I and Dr. Sambhav Shah here from the Pediatric Spine Department would be more than happy to take care of these kids in future.
Thanks a lot. And if you have any more queries, we are happy to answer your questions. You can meet us at SRCC or even email to our hospital. And we'll be happy to answer all your queries. Thank you. Thanks, Akhil.
Thank you, Dr.